from various specialties: endocrinologists, cardiologists, nephrologists, primary care physicians across MEA region. I would like to extend my heartfelt thanks to our esteemed speakers: endocrinologist Professor Dr. Celal Altay from Iraq, nephrologist Professor Dr. Ahmet Al-Karai from Egypt, cardiologist Professor Dr. Hani Sabur from UAE. Today, we will focus on cardiorenal disease burden, SGLT2 inhibitors as a standard care across global guidelines, and Forxiga's efficacy across approved 3 indications: type 2 diabetes, chronic kidney disease, and heart failure. We will also explore real-life interactive patient cases for the management of cardiorenal patients. In total, we'll have 2 hours. In the beginning of each session, we will solve interactive patient cases. Professor Dr. Celal Altay will share his clinical insights about type 2 diabetes disease patients. And Professor Dr. Ahmet Al-Karai will share his experience on chronic kidney disease diagnosis and treatment journey. And Professor Dr. Hani Sabur will share guideline updates and holistic treatment management for heart failure patients. Let's begin this exciting journey together. Once again, welcome and thank you for being with us today.
Dear delegates, today you'll see an AI-based patient simulation before each speaker's presentation. You will take history, order laboratory tests, diagnose, and treat those patients. You will have 10 minutes for each patient. You will have 3 total patient cases. And after that, we generate an anonymous report, and the speakers will give you feedback based on the delegates' overall results. And let me show you how it works. Okay, when you open the system, you will see 3 cases listed in order, as you can see in the screen right now. You will start with the first one. After you complete it, our faculty will give feedback based on the anonymous report, as I mentioned earlier. Then you will move on to the second and third cases in each round. And I'll show you the case picture so that you know which case we are talking about. When I click on the body case, for instance, in here, you're going to see a brief summary of the patients. To start, you can click anywhere outside that info box and start. Here's the AI-based history-taking part. You can ask your questions here, and your patient will answer your questions. To save time, you just focus on the routine question, please. You will normally ask to a patient like this in your daily practice. And try to avoid one-word questions. And you can move through the applications. As you can see in the upper right-hand side, there are 2 arrows. And you can use those arrows to navigate these applications. Next, you're going to see the physical examination section, in which you can choose, for instance, palpation in the upper right-hand side. So you can see in here. And you can hover over this patient case. And let's click on this blue dot representing the palpation you do in this region, and you can see in the left-hand side the results. And if you like to have extra information about this patient, you can click on the Get X-ray Info button and BMI and click this tick icon to see also BMI in here easily. And next, we're going to go to the laboratory. You can tap the Please Select button in here to choose a laboratory test category, let's say biochemistry, and select all the tests here. Or you can pick one individual test, as I do it right now, and click on this icon to see the results. Actually, this is the result, and this is the normal range for this particular test. You can view this test results in here easily. In the next section, type the name of the imaging test. Actually, we are in the radiology part. Type the name of the imaging test you want, then click on it in order to view the result. Like in this case, I'm going to order some abdominal ultrasound and then click on the picture to see it, a bigger version to see what's going on with your patient. And then we are going to move on to the diagnosis, in which you can do 2 things. First, you can make a selection by clicking on the Make Selection button, and you can select one or more diagnosis, or you can actually type your diagnosis and you can actually go to next section, which is the last section within our simulation. You can write down type in your treatments in here, or select from the list of the treatment choices that are designed for your needs. And then after that, you can click on the finish button in here in the upper right hand side. You can leave a comment. You can type in your comments in here and send it. And you can rate your case in here easily. And you can go back to the case list. And this is how it goes. And now I'm going to show you the QR code. You can scan this code with your mobile phones to access the simulation, or you can click the link my colleagues now shared in the chat section. You can see it there. And we have 10 minutes, and I'll kindly remind you of the time as we go along. You can start now.
We'll have 10 minutes for case solving. Please scan the QR codes and select Mrs. Betty.
Important to register and participate. Have any problem, please text in the chat.
We have 5 minutes left.
delegates. Actually, our case solving time is now over. And I would like to invite Professor Altay to start the presentation with the case summary.
Thank you.
Thank you.
Thank you, Doctor. As you solve the case, dear colleagues, the case detail is a lady, middle-aged lady, an old lady who came for routine checkup with a burning sensation in her feet. She's 67 years old. She has diabetes for moderate duration, which is 8 years. Her BMI is 32. She's in grade 1 obesity. She's a retired midwife with married to 2 children. On examination, as you may seen, Betty is using metformin and a DPP-4 inhibitor combination. She is grade 1 obese. She has burning sensation. Not compliant neither with exercise and neither with her medication, and she does not smoke or consume alcohol. And she complains of fatigue. Thank you. And as you can see, in the blood pressure is nearly controlled. Her respiratory is normal, pulse rate is normal and regular. But her GEFR, if you can observe, is a 55 milliliter per minute, which corresponds with CKD grade 3A. Her ACR test showed 24 milligram per minute creatinine, which is normal, A0. In this case, it was valid. The spot test was normal, and total protein is normal in her blood, while her HbA1c is 7.5. Other lab values are within the normal limits. Her abdominal ultrasound was shown everything was normal, apart from a slightly enlarged liver, in which it was 16 centimeter in length, and parenchymal echogenicity was homogeneous, which corresponds with hepatic steatosis, which is a common finding in people with diabetes, prediabetes, nearly obese people, which is called, in between parentheses, a fatty liver. It corresponds to grade 1, grade 2 steatosis. Other findings that the size of the kidney were normal, and the adrenals and other splanchnic areas all normal.
Now, we will move on to the report with your permission, Professor Altay, to review the anonymous
sir.
findings. Just a second, please. These are the diagnosis results.
Yes, Doctor, I'm very pleased with this, as I can see that most of them, they know she has diabetes, and let's say the minority of our people diagnosed with CKD. And they have all the right, because many of our colleagues are unfamiliar with the KDIGO-ADA last consensus, in which they state the normal CKD, the normal eGFR is above 90. In this case, it was 55, which is correspond to grade 3A, which is a form of CKD, although it is asymptomatic. Yes, minority of us, right, she is obese, hypertensive. Yes, she does have these diseases. And she also, most probably, dyslipidemic, although we didn't show this. Coronary artery disease, although not mentioned. Sleep apnea, probably she has, but we don't mention any of that. As for SLE and osteoporosis and COPD, I don't think it is likely. Yes, she has diabetic neuropathy, although only 2 people wrote, and she has diabetic nephropathy, although one of our colleagues only wrote this. Yes, her diabetes is uncontrolled, you are right, and she has diabetic peripheral neuropathy, but only one colleague wrote this.
May I move on to the treatment?
Yes, sir.
Thank you.
I'm glad that many people added Forxiga to the current treatment because she's in this case. As per the GLP-1RA, which are still expensive, especially in our MENA region, I don't think till now the KDIGO added it to the list of important CKD first-line treatments, either for decreased eGFR or for micro or macroalbuminuria. DPP-4 will be, she already on DPP-4. I don't think this is the right answer. Not adding anything to her medication, although she's in stage 3A CKD, is really some type of inertia, if you permit me to say. Basal insulin and sulfonylurea will not be useful. especially basal insulin, because she's not that highly uncontrolled. She's 7.5. Pioglitazone, it's okay to add it, but it won't have any effect for managing her CKD. Glenide is like sulfonylurea. It does not have any role in this. She's already on metformin, all right? So yes, dapagliflozin was added, as many of our doctors say right here. They are right to add duloxetine and pregabalin because they are first line against peripheral neuropathy. One of our colleagues added an antihypertensive. I agree with him. Okay. And vitamin B complex added, maybe for the neuropathy.
Yes.
And thank you, Doctor.
Thank you.
As with this, we want to start our presentation. After permission, dear colleagues, we have the cardiometabolic syndrome, or CKM, or cardiorenal syndrome, which is really a spectrum of diseases that are still connected together. As you can see, many of our people have ASCVD or heart failure, in which they are classified as having cardiovascular diseases. As per prevalence, including heart failure, nearly 40% of people with cardiovascular disease, they have form of CKD. And more than 1/4, more than 25% of our hypertensive people, they have CKD. While looking for CKD, yes, nearly 70 to 80% of them will develop heart failure. And the metabolic diseases like prediabetes, and especially in our cases, type 2 diabetes, is nearly as highly prevalent in 36. We know that at first diagnosis, we're going to have diabetic nephropathy at diagnosis more than 22% of the cases. So we have to be aware of the interconnectivity of these. The burden, yes, it is a burden because CKD, it affects nearly 840 million people worldwide. Type 2 diabetes, the other pandemic, which affects 537 million people around the world. And heart failure is also common. It affects 64 million people. This puts all burden on impact and on our patient, and even on quality of life on other caregivers. And of course, they are associated with increased expenditure cost worldwide. So a big problem is asymptomaticity. As you can see, especially CKD and heart failure in the first stages, they are really asymptomatic. Let's say the stages we want to interfere. Up to 95% of CKD stage disease can go undiagnosed. This is a great number because they are symptomatic. In the US, nearly 78% of US adults are diagnosed. But let's say if we project this to our MENA region, this number is much, much less. People with diabetes go undiagnosed unless they have some symptoms. And 4% of people with heart failure are diagnosed, but only half of them, they have been diagnosed. Let's see if the need for early intervention, as you saw, because early intervention means less mortality, less morbidity. In the case of type 2 diabetes, every decade of earlier diagnosis, because we know type 2 diabetes is shifting towards earlier and earlier ages. Even in children right now, it's present. So every decade you diagnose the patient, he will lose 3 to 4 years of his life, lower life expectancy. As you can see in the your left-hand screen, the all-cause mortality, and right-hand screen, the cardiovascular death. And you have the male and female life expectancy. The male is a little less, as you can see. In this study, they showed that you can see that on your y-axis, there is the years of life expectancy with no diabetes, and right-hand screen, female, left-hand screen, male. As you can see, diagnosing early, especially in the 30 years as the red line, and 40 years at the fourth decade, fifth decade by the blue line, you can see that they lose many years of life. And this goes the same in women. So there's a need to apply intervention. We need to screen. We need to diagnose earlier so we can intervene earlier in these people. So a simple study was done in a UK clinical data research data link. They compared for nearly 5 years people who have type 2 diabetes diagnosed after 1 year. They are newly diagnosed. It was a big meta-analysis. It involved nearly 105,000 patients, and they divided them into two arms, in people in which they have immediate therapy intensification, and other people in which they delayed the intensification for 6 months, and only 6 months, and these two arms were followed for 5 years nearly. What we saw is only 6-month delay. Look at the significant increased risk of MI. Look at the hazard ratio is 1.67, and significant increased other CV event risk by 1.6. So we saw that only 6-month delay can lead to these risk. And the next slide, you're going to see the addition Europe. It was the meta-analysis done for the English-Danish Dutch study in the intensive therapy of people. And what do they have after follow-up, as you can see here? So on your y-axis, you have the cumulative incidence of CV events, and you can see that intensive treatment at first and routine care, they have reduced mortality. Look at the 3-year delay in the purple line, and look at the 6-year delay in routine care, which happened in a lot of our people, especially in the Middle East. They come to you delayed, and doctors delay the treatment. The incidence is raising nearly more than 10% in incidence of cardiovascular events. What about heart failure? This is the second most common. In heart failure, a specific entity of cardiovascular diseases, it is nearly asymptomatic, or they have mild symptoms at the start, like dyspnea on exertion or fatigue. ALS, for the last 21st century, we didn't diagnose, we didn't achieve much like in stroke or MI. You can see that from 20 to 2016, only a 6.6 improvement in mortality was seen, as you can see in these slides. Thank you, Doctor. Proceed. Here we can know that we have variable risk factors, okay? And these variable risk factors for type 2 diabetes and for heart failure, like presence of CKD, CVD, other treatments. As you modify them, you can have a normal life in every decade. But when you have more unmodified, or let's say more out of target risk, you're going to have more incidence of mortality and morbidity. Next, please. So a comprehensive treatment should be done through guideline medicated treatment or medical therapy. You can see that survival at the early initiation of GNDT, survival is pretty well. Well, if you miss the opportunity and delay your treatment, you're going to have more mortality. And prognosis is very, very bad for people with no intervention. Another big problem is CKD, and it's asymptomatic. And we all know that eGFR declines, as you can see in this observation. At the meantime of diagnosis, most of our people have reached stage 3A or even 3B, in which the symptoms start to evolve. And what we want to do is screen, not only for eGFR, but also for urinary ACR, albumin creatinine ratio. This is the KDIGO classification. As you see, it is very common for you. I think you see on the y-axis is the grade 1 from more than 90 in normal people to end-stage kidney failure, which is G5, which is below 15. And the A1 is normal albuminuria, A2 is moderate, which is microalbuminuria, and more than 300 ACR is macroalbumin. You can see the red, dark red and red. These are very high to high risk people. They also die more from cardiovascular disease than dying from end-stage kidney disease. They should be all treated and referred. And you have to early intervene in order for the natural decline of GFR not to occur. By applying an SGLT2 inhibitor earlier, like we said, by applying for Zika, we can see that its main thing is reducing the A1C. It reduced it early at the first 6 weeks, as you can see in the red line, and it was constant throughout the 52 weeks of study, the 1 year of study. And of course, we had a beneficial effects like a reduction in systolic blood pressure and a weight reduction, which are all beneficial in managing the CKN syndrome in these cases. The DECLARE team was studied on the events were more than 8 years ago analyzed, but it differs from other studies in which they had different types of UACR patients. You have micro, macro, and normal albuminuria levels. What were the exploratory endpoints, not the MACE here, these are exploratory secondary endpoints. Like you can see, renal specific outcome were reduced by 47% in diabetic people. And hospitalization for heart failure was reduced by 27%. And this what induced the next studies like DAPA-CKD and DAPA-HF. In summary, these people with cardiorenal disease need to be managed holistically. Do not think about one organ, please. When you have a CKD patient, we think about developing heart failure. And people with heart failure or other CVD, we think of them having CKD. And of course, type 2 diabetic people are having a lot of microvascular complication and lot. We have to think about holistic approach to these people. So CKD, diabetes, and heart failure are major public health concerns, and they have a wide range impacts on the life of patient, their caregiver, their works, and their economic lives. But ALAS, despite the high prevalence and burden of CKD, type 2 diabetes, and heart failure remain underdiagnosed. They are diagnosed in late stages in which intervention will lead to a little reduction in mortality. Therefore, we beg you to have earlier diagnosis of cardiorenal disease, especially to slow the rate of morbidity, slow the eGFR decline, to slow the heart failure decline. We all know since the UKPDS and so much studies later that intensive glycemic control delays the onset and progression of cardiorenal disease. It delays micro and even affects macrovascular complication. That's for we have Forzigen to help us halt the worsening of nephropathy and even halt the worsening of hospitalization for heart failure. And we have combination treatment. I prefer personal combination treatment at first, like Forzigen plus metformin, to achieve their good glycemic control in type 2 diabetes. With this, I think I conclude and leave the space to Dr. Metialci.
Thank you very much, Professor. And now that Professor has thank you. Now that Professor has finished, we'll move on to the second simulation, and you're going to again access the next case with the same QR code actually, but this time around you're going to solve Mr. Donald's case by scanning the same QR code. If the app is already open on your device, you don't need to open again, scan the code again, and you can go directly to the second case. And my colleagues also share the link again from the chat section. You have 10 minutes. Thank you.
And remember that you can choose all the things that you can as a clinical case. Please feel free to ask in the app. You can show or you can ask all the labs. You can ask for the clinical exploration. So this is very good app to feel comfortable and to ask and see for all the studies that you need to make a diagnosis. And you can even come back if you have missed some labs or radiographies or anything that you need. At the end of the sessions, we will have the Q&A. So after we finish the clinical case, you can add your questions. And at the end of the clinical cases discussions, we will discuss the Q&A.
3 minutes to complete the case.
Hello again. Thank you for your engagement. The time is case solving is now up. At this point, I would like to welcome Professor El-Karaye to kick off the presentation with the case summary.
Okay, hi everyone. Thank you for your interaction. And here is our case. Mr. Donald, as you see, is a 42 years old male patient. He's presenting for a routine checkup. He's been diagnosed with diabetes 10 years ago, and he is of average height and weight, and his height is just a little bit above the average, 26. He works in a private company. He is married with one child, and he's a university graduate. He has already been 2 years ago presented to the nephrology unit with leg swelling and high blood pressure, and due to his renal impairment with proteinuria of 5 grams per day, he was planned for a renal biopsy that was undertaken, and the result of the nephropathology was back as FSGS, focal segmental glomerulosclerosis. He's currently on a RAS blocker, ramipril, 5 milligram ACE inhibitor, and he had received already methylprednisolone for 9 months for his proteinuria, and the proteinuria already decreased over 100 milligram in the last 2 checkups. It was between 600 and 850 milligrams, so a little bit increased from his baseline. He's non-smoking, non-alcoholic, and he is on a salt-free and protein-restricted diet to keep with his CKD. Other findings were all normal. And here is his physical examination and labs check. Blood pressure is 135 over 87, a bit higher than the average. Respiratory rate is a bit elevated, 24 per minute, which is a little bit maybe of an anxiety or so. Pulse is 76 per minute, and all other findings are normal. His albumin is pretty okay, 4 grams per deciliter. His BUN is 18 milligram per deciliter on the edge, and serum creatinine is 1.6 milligram per deciliter. That makes an estimated GFR according to the CKD API creatinine-based equation of 65 milliliter per minute. His total protein is 7.4 gram per deciliter, and his uric acid again is on the edge of 6.5 milligram per deciliter. As you can see, his lipogram is on the pretty okay side, except for the LDL cholesterol, which is 106 milligram per deciliter. Probably should be lower than this. As you might know, he has a cardiovascular risk equivalent to 70 might be better option for him. And his 24-hour urinary protein is 165 milligram per day, keeping with a urinary PCR of 1.7. And no, please, yes. Ultrasound, the kidneys are okay, more or less average size, maybe glycogenicity is mild increase as you might expect for his FSGS, and else everything is okay, and there is no abnormal stones or cysts or whatever. And the biopsy, as you have seen, 25 glomeruli in total. Two of them are already globally sclerotic, and he's 42 years old, so this is again on the border. 5 glomeruli had segmental sclerosis with synecdoche, and the immunofluorescence showed IgM and C3 positivity, which again goes aligned with the FSGS diagnosis. So this is a focal segmental glomerulosclerosis patient, proven by the kidney biopsy. Chest X-ray is normal. And next, please.
Yes, we now move on to the report with your permission.
Yes, of course. Here, as you
Just a
can see,
Just a second, please. I'm so sorry. I need to go to refresh the report. Okay.
okay. So these are the questions, and we'll look for the answers. He's a hypertensive patient, 36 years of age, said so, which is right. He's a CKD secondary to chronic GN. Again, this is absolutely right. He has an FSGS as a cause of his CKD beside the diabetes, and this is okay again, 23 of you. He's type 2 diabetic. Yes, I don't know why you missed that. He's 10 years diabetic patient as well. Hyperlipidemic. He's a borderline dyslipidemic. This is true. And his CKD stage 3B, as you might see that his GFR was, how much was the GFR? It was below the 45. So no, it was above the 45. So it's probably not 3B. It might be 3A.
Would you like me to go back to presentation?
Yeah, please. Yes, if you can go to the GFR just to be yes, GFR was 65 milliliter per minute. So actually he's a stage 2, not stage 3 at all. Thank you for keeping with that. And please note that even with a serum creatinine of 1.6, but at his age and his body build is okay. He's definitely not obese because his BMI is only 26, so he might be just a little bit of overweight, but not obese. CKD is definitely CKD, and we've mentioned earlier his CKD stage 2, and he has albuminuria, so he's a stage 2A3 as well. He's not currently coronary.
Professor Alcaray, can you hear me?
I think we lost his connection and he'll
Yes.
come back soon.
If you wish, we can move on to the presentation away, or maybe we can go to the second the case, third case.
No, we can wait for him. He will
Okay.
connect.
Okay.
Only as a reminder, you can submit your questions, and then at the end of the session, we will have the Q&A.
Am I back in?
Yes.
Yes, we
Yes, you are.
I'm so sorry for the interruption in the connection. And as we've seen, that's okay. Everything is, as we mentioned, there is no AKI, the patient's hypertension, diabetic, this is true. Please go to the next. So if we go for the treatment, would you add Forxiga for the current treatment? Most of you said yes, and this is absolutely right. Not only because he's a diabetic patient, but he is a diabetic and as well, he is FSGS CKD. So we can use Forxiga, as you know, for a non-diabetic kidney disease, specifically those with chronic GN, mainly IgA nephropathy and FSGS, and then membranous later on. I do not add other medication. This is not true. The patient has a proteinuria in spite of being on RAS blocker, and he is already at risk of progression of GFR. You have to add isoprostol and add telmisartan. There are some reports of telmisartan having a higher anti-proteinuric effect, but ramipril definitely is a choice for this patient. Methylprednisolone to the existing treatment, only 9 of you said they would do so. I don't think this is a good option. The patient is not in an active inflammatory state that he would need steroids, and definitely there is no role for steroid in cases of chronic FSGS with a proteinuria less than 1 gram, as in his case. I add an angiotensin receptor blocker. We all know that the on-target trial, you cannot add ACE and ARBs altogether, though this is the wrong choice. I do not add any other medication to existing treatment. This is wrong. Yes, you add salt-free diet. Yes, you evaluate the term of treatment, but you still need to add, to avoid the inertia, as previously mentioned by Professor Galal, you have to add definitely other arms. Actually, you might add more than one arm. You might add the SGLT2 inhibitor and maybe even the non-steroidal MRA. Okay, let's go for the next. Okay. So let's wrap up the evidence why we should add an SGLT2 inhibitor, particularly the dapagliflozin for that patient. As you have seen earlier, the risk of kidney metabolic outcome and how it goes. And here is the DAPA CKD, where it enrolls diverse population of patients with CKD, whether with diabetes or non-diabetic. As you have seen, almost 58% had a diabetic nephropathy, and the rest of the patient have other etiologies for CKD, like glomerulonephritis on top, and the main was IgA nephropathy and FSGS and membranous nephropathy, ischemic hypertensive nephropathy in another 16%, and unknown or other causes in almost 10%. So a big portion of those patients, almost a third of them, were non-diabetic. And as you know, these were almost 4,000 patients. All of them were adults above 18 years with a GFR wide variety from 25 to 75, as well as urinary ACR from 200 till 5,000. So most of our patients that we meet are fitting in this group of patients. There were almost 98% of them are stable on a dose of ACE inhibitor or ARBs for more than 4 weeks, and they have been randomized and followed up for 2.4 years. And as you've seen in here, that almost 270 patients were in the IgA nephropathy, diagnosed by IgA nephropathy, and these comprise 17% of the patient without type 2 diabetes at the baseline. And this is a very big portion, maybe was even more than those in the IgAN stop trial. Next, please. Yes, And here is the outcome, magnificent outcome. And please read the number in the proper way. It's not only the relative risk reduction, which can be deceiving with the big number of 39%, but it's also the absolute risk reduction with this 5.3% in the primary composite outcome of the DAPA-CKD, which entails the declining of the kidney function, the being end-stage kidney disease, in need for renal replacement therapy, or even cardiovascular or renal death. But the most important here is that number. It's the number needed to treat, which is only 19 patients, which is really a very small number. You need to treat 19 patients to get this marvelous outcome in one of these patients. So this is a very good. The more the number needed to treat is lower, the more is the effective and the protective effect of the drug. Next, please. And here is the pre-specified analysis for the use of the Forxiga across the diverse CKD etiologies. And this gives you more confirmatory evidence that it is not specific for a specific disease, but it goes through all diseases. Diabetic nephropathy, here you can see the relative and absolute risk reduction, and the forced plot is here favoring the Forxiga with the two arms across the midline, which means that, or the even breakpoint, which means that it's a very strong, a little bit lesser effect, but still toward the favoring of the interaction. Again, the glomerulonephritis, as you can see, even better than the diabetic nephropathy, other or unknown, again, better or as equal as. This is the primary composite outcome in the kidney, and this is the heart, and this is the all-cause mortality. Again, all the results, as you can see, is toward favoring the Forxiga, and as well the composite cardiovascular death or hospitalization for heart failure, which was the secondary outcome, not the primary, in the DAPA-CKD study. Next, please. And here, again, across the diverse CKD etiologies, enrolled diabetes, whether with or without, with stages overall, and stage 4 and stage 2 and 3. Our patient was stage 2, Donald, with a GFR of 65 milliliter per minute. You can see all favors the Forxiga, even in subgroup of patients with diabetic or ischemic, all glomerulonephritis. Glomerulonephritis is pretty stronger evidence. Maybe the hypertensive or ischemic one is the least evident in this group. Next, please. And the secondary endpoint, the all-cause mortality, whether renal or cardiac or all-cause mortality, again with an absolute risk reduction of 2.1 and the relative risk reduction of 31. Next. And here is the outcome that you can see in IgA nephropathy, in FSGS, in membranous nephropathy, the three major types that we saw in our practice for patients with chronic GN. It's 71% with an absolute risk reduction of 11. A marvelous number needed to treat 9. This was not accomplished in any previous trial, as if IgA nephropathy have a primary treatment with the Forxiga in this situation, and the difference in the annual decline in the GFR is 2.4 milliliter per minute annually in favor of Forxiga. That's to say, a 10-year treatment with the drug can save the patient of a decline of 24 milliliter per minute, which can keep the patient off dialysis for years and years, maybe even decades. FSGS, again, number needed to is 33, and the relative risk reduction is 38. And this is our patient, Mr. Donald, with again a 2 milliliter per minute decline in the rate of decrease of the GFR annually in favor of adding dapagliflozin, as well as in membranous as well, 1.57 in favor of the Forxiga. Next, please. And here is the albuminuria, and you can see reduction in the albuminuria, very, very strong effect in the reduction of the albuminuria. It's like 30% almost reduction in the albuminuria between the placebo and the Forxiga. And as you know, albuminuria still rests as a surrogate marker for progression of CKD and the evidence for that is that it is now one of the parameters for definition of CKD with the A1, A2, A3, as you have seen earlier. Next, please. And here is the KDICO recommendation for the use of SGLT2 inhibitor. And if you gather those recommendations together, you would find that almost every patient with a CKD should be using SGLT2 inhibitor. Here is a strong recommendation with a GFR of more than 20 milliliter per minute with a urinary album creatinine ratio of more than 200, or with a heart failure, irrespective of the level of albuminuria. So any patient with heart failure and any form of CKD, even without albuminuria, should be receiving the dapagliflozin. On the other hand, if the patient has a GFR more than 20 milliliter per minute, he should receive, and he is diabetic, so he should receive SGLT2 inhibitor immediately. And here is a suggestion, not recommendation. And with the urinary album creatinine ratio less than 200 milliliter, these are suggested to receive an SGLT2 inhibitor. So now you have almost SGLT2 inhibitor for proteinuric or non-proteinuric, with heart failure is definite, with diabetes definite, and with a GFR more than 20 milliliter per minute, even if not proteinuric. It's a suggestion, not a recommendation. Second, please, next. And this is the European Society of Hypertension guidelines, again, fostering the same point. Recommendation 1A, diabetes or non-diabetes with a nephropathy more than 20 milliliter per minute, CKD, use it. Heart failure, recommendation 1A for HFrEF and for HFpEF after the DELIVER trial as well. Next, please. And here is the, despite of the good uptake in SGLT2 inhibitor, and the message that we all know, more patients with CKD could benefit because only 54% of eligible patients with stage 3 and 4 are using RAS inhibitor or SGLT2 inhibitor. So this is inertia. This is definitely inertia, and we are responsible for that. Now we know that this is a marvelous drug. This can keep the patient off the machine for years to come, and we are still reluctant in a way or another in using the drug with no evidence, with no, reasoning for lagging beyond the evidence. The use of renoprotective drug lowered the patient with CKD without type 2 diabetes. So a dramatic expansion of guideline-driven medical therapy is supported by high-quality evidence and improving the CEV and mortality outcome. Next, please. So this is to summarize our final conclusion. There is a significant reduction in the risk of primary composite outcome by the DAPA-CKD versus placebo, which is the declining of the kidney function, the reaching the end-stage kidney disease, the composite renal or cardiovascular death. There's consistent cardiorenal and mortality benefits across the diverse CKD etiologies, whether diabetic or non-diabetic, maybe the least with the ischemic, but with the glomerular disorder even was much more better than the diabetic. First and only SGLT2 inhibitor with mortality benefits in patients with CKD with or without type 2 diabetes. Renal benefit versus placebo in patients with IgA, FSGS, and membranous nephropathy was offered, and specifically for IgA and next for FSGS. Significant reduction by 29.3 of albuminuria, which is a surrogate marker for the expansion of renal disease and the progression. So for SEGA are now standard of care, and we have to increase implementation and decrease our inertia and patient inertia for the uptake of these guideline-directed medical therapy. And by that, I thank you for your attention during the presentation and for your answers. Thank you.
Thank you very much, Professor Alcaray. Now we are going to move on to the Susan. You see, Susan, and we are going to solve this case as a less patient case. Actually, you can scan the code, and if the system is open in your mobile phone or computers, you're going to go to the third case, please, and you have 10 minutes.
I will encourage you to remember the last case. We have followed 2 previous cases that were very important and very interesting. So now that you are more familiar with the app, it's going to be easier to solve this last one and to follow and ask for the labs and radiographies and anything that you need for exploration and to get the last diagnosis. So please free if you have any questions in the chat about the case, but well, we are in the last case for today, so please, the important case of Mrs. Susan. Only a reminder, we still have time to continue with the case. And if you are joining us at this moment, please don't forget to scan the QR. And we are in the third case, Mrs. Susan. Please, still working on it. Then we will have the discussions with Dr. Sabur. And remember that you can choose any options that you would like to know about the patient.
Dear delegates, thank you for working through the case. This stimulation time is now up, and I would like to invite Professor Mr. Sabur to start the presentation with the case summary.
Okay, so thank you very much for participating in the interaction and the case diagnosis. So this is a 69-year-old lady presenting with shortness of breath and palpitation with exertion. She has exertional dyspnea. She has orthopnea and PND, and she has pedal edema. She does not report syncope. Her history includes hypertension, type 2 diabetes, coronary artery disease. She had a stent placed 15 years ago. Her current medication includes an angiotensin receptor blocker, valsartan. She's on a fairly high dose of diuretic, which is torsemide. She's on a beta blocker, carvedilol twice daily. She's also on rivaroxaban 20 and metformin. Next, please. So if you look, her blood pressure is not very well controlled for somebody with cardiovascular disease. She is somewhat tachypnic, and she has a elevated basal pulse. Remember, the target heart rate in a patient with cardiovascular disease will be less than 70. She also has lower limb edema, which we mentioned before. So her creatinine is 1.2 milligrams per deciliter. She's anemic. She's euthyroid. Her LDL is 101, which for a patient with coronary artery disease and diabetes, the target is less than 55 milligrams. Her fasting blood glucose is 223, HbA1c is 6.9. And I think what clinches the diagnosis for you here is the NT-proBNP, which is 1,469. So as you know, in the outpatient setting, it should not exceed 125. Anything above 125 is diagnostic of heart failure. Next, please. So what do we see here on the ECG? It wasn't part of the original discussion, but you see she has atrial fibrillation. She also has, so there's no P waves, and it is irregularly irregular. There is a single PVC here in the middle of the screen, and in addition, you can also see the following. You can see the presence of Q wave in lead 3 and lead 2. And you might say that there's somewhat of a low voltage in the limb leads as well. So this poor R wave progression in the anterior leads. Next, please. So this is the echo. So ultimately, when you see a patient like this, an echocardiogram becomes important, but it shouldn't limit you in terms of the treatment. I'm going to explain why a little bit later. So the ejection fraction is 55%, which is normal. There's biatrial dilatation. The E to E prime ratio is 14. She has significant tricuspid regurgitation and pulmonary hypertension. And the left atrium is dilated. The left atrium volume index is 64. So you have several features which describe to you a normal ejection fraction, in spite of which the patient has heart failure. There's atrial dilatation, there's high filling pressures, there's pulmonary hypertension, and there's impaired relaxation, what we call diastolic dysfunction. Next, please.
Now, I'm going to show the audience the report. Professor, just a second, please. Yes, please.
Right. So these are your diagnoses. So obviously, everybody noted that the patient had, out of 150 answers, diabetes. About half said that the patient had heart failure with preserved ejection fraction, hypertension, coronary artery disease. This is clear. She also has hyperlipidemia. She does have pulmonary hypertension. She does not have evidence of acute pulmonary embolism. And I'm not sure where we get the evidence for sleep apnea syndrome, but you could certainly see a patient with diabetes, overweight, metabolic syndrome, and hypertension having sleep apnea. It's present in about 40% of patients like this. There is, of course, evidence of atrial fibrillation on the ECG. She's also markedly anemic. And so the creatinine is 1.22, which would give her a GFR less than 60. So she does have chronic kidney disease. Is the blood pressure well controlled? It is not for a patient with diabetes and comorbidities, and certainly not controlled for a patient with heart failure and coronary artery disease. There is no evidence of COPD. We did not mention that. And pulmonary artery aneurysm is not part of the differential diagnosis here. So in terms of the treatment, I think this patient needs a lot of treatment, right? There's a lot of things that are missing. So adding SGLT2 inhibitor is absolutely essential here. I would suggest to add the SGLT2 inhibitor even before you get the echo, because as you know, in the DAPA-HF study and in the DELIVER-HF study, similarly, the SGLT2 inhibitor is beneficial with or without reduced ejection fraction. The patient also has diabetes with target organ damage and therefore would benefit from the addition of a high-intensity statin to lower the LDL to 55. The patient's already on torsemide. The torsemide does not seem to be working. The BNP is very high, so you could suggest a higher dose. Clopidogrel, I think, has no value in this patient. She does not have any active ischemia. She's already on rivaroxaban for management of stroke and AFib. So not adding medication is essentially a mistake. You have a diagnosis that's fairly serious here. Sulfonylurea has no benefit in terms of the outcome, in terms of heart failure. Carvedilol, she's already taking carvedilol at a higher dose. Now, not adding anything to the treatment and responding in 3 months is pure inertia. I think that's also incorrect. Remember that all DPP-4s are neutral in terms of cardiovascular events. Saxagliptin actually increases heart failure, so this is a mistake. Ramipril, while it has some evidence in prevention of heart failure, the other option is to add sacubitril valsartan, which actually was seen in the Paragon study. Substituting bisoprolol for carvedilol would only be useful if the patient had history of bronchial asthma. Now, the addition of GLP-1 has recently been studied in STEP-HF and STEP-HF diabetes study, and I think that might be reasonable on top of standard, which includes SGLT2 inhibitor. Basal insulin has no impact on heart failure hospitalization. Nebivolol has been studied in patients with heart failure and preserved ejection fraction, particularly over the age of 60 in the senior study. Ivabradine has no role in patients with atrial fibrillation. It does not control the heart rate in AFib. We already mentioned the addition of dapagliflozin under its scientific name. So pioglitazone is actually contraindicated in heart failure. And if a patient with heart failure presents on pioglitazone, you should certainly stop it or reduce the dose significantly. Enalapril and ramipril are ACE inhibitors. They are non-inferior to sacubitril valsartan. And adding metaglenide doesn't seem to have any benefit. Again, metoprolol is not specifically indicated in heart failure and preserved ejection fraction. Iron supplementation, yes, any patient with heart failure, if they have a low transferrin saturation, less than 20%, or low ferritin, would benefit from intravenous iron supplementation. Now, SGLT2 inhibitor is correct. Adding sacubitril valsartan 200 twice a day, yes, that is a correct answer, because in patients with heart failure and preserved ejection fraction, the Paragon study, on top of standard of care, there was significant reduction in heart failure hospitalization, and this does comply with the US label. So thank you for this variety of answers. Hopefully we'll have some time to go through each one of these in turn. So what is the scientific evidence of the use of dapagliflozin in particular in heart failure? So whether you had a reduced ejection fraction, which was DAPA-HF, less than 40%, or you had an ejection fraction above 40%, which was DELIVER, these heart failure. Next, please. So with preserved ejection fraction or reduced ejection fraction, these patients, more than a half, were not diabetic. So yes, it works very well in diabetic patients, but it also was included in the non-diabetic patients, which is why we are advocating for its use specifically in diabetics with heart failure, but more generally in any patient with heart failure, regardless of the ejection fraction. They also looked at some unique subgroups, looking at the GFR, less than 50% in the preserved ejection fraction and also in the reduced ejection fraction, and looking at patients who are recently hospitalized or patients who had improved on medical therapy. Next, please. So if you look at the patients with EF above 40%, there was an 18% reduction of CV death or worsening heart failure over the next 3 years. Number needed to treat 33. If you took patients with a reduced ejection fraction, a sicker population, there was an absolute risk reduction of almost 5% over 2 years, 26% relative. Again, a very hard endpoint, CV death or worsening heart failure, number needed to treat 21. So the conclusion is very obvious. If you use dapagliflozin in a patient with a low ejection fraction, a normal ejection fraction, or anything in between, you will reduce cardiovascular death and heart failure hospitalization over 2 to 3 years, a very rapid change in the endpoint, a very rapid separation of curves, very robust, statistically significant, and clinically very meaningful for these patients. Next, please. So when you look at the difference, when does it occur? It occurs actually very quickly, within day 28 in the patients with reduced ejection fraction, and by day 13 in patients with preserved ejection fraction. And the treatment effect is very large, almost 50% reduction of CV death or worsening heart failure compared to placebo. So here, inertia should not occur. We are talking about a difference of death or heart failure hospitalization within less than a month. So if you see a patient like Susan in your clinic and the BNP is high, don't wait for the echo, don't wait for the cardiologist, immediately start the patient on SGLT2 inhibitor, because this will immediately impact their outcome, and waiting longer means the patients will accrue or maybe die or have a heart failure hospitalization. Next, please. So when they looked at these patients who had a recent hospitalization or have to start the SGLT2 inhibitor in order to reduce the likelihood of cardiovascular death or mortality. And if you compare those two groups, the patients who did have a heart failure hospitalization were obviously much sicker. They had a higher incidence, almost a 20% higher likelihood of having another heart failure hospitalization or death than somebody who was enrolled in the outpatient clinic. So remember, if you see them in the outpatient clinic, it's fantastic. It's an opportunity to prevent worsening, prevent heart failure, prevent a cardiovascular death. If you see them in the hospital or shortly afterwards, it is essential to start this therapy as soon as possible. The benefit is not attenuated by the duration or the time of diagnosis, but the disease itself progresses very rapidly once it worsens to the point of coming to the hospital. I hope this point is clear in terms of the explanation. Next, please. So what about patients who had an improved ejection fraction? So in the guidelines, we have now patients who are getting guideline medical therapy, i.e. patients on beta blocker, sacubitril valsartan, mineralocorticoid antagonist. These patients improve their ejection fraction from less than 40 to over 40, sometimes up to the normal. What's the benefit of SGLT2 inhibitor, particularly for SIGA, in the DELIVER study? Well, in terms of the primary outcome, there was a 26% improvement, cardiovascular death, almost a 30% improvement, and all-cause mortality is basically the same. So even in patients who have improved their ejection fraction on Entresto, beta blocker, and MRA, addition of the SGLT2 inhibitor dapagliflozin confers an additional benefit of heart failure prevention and cardiovascular death. So I think we have to add it to all patients. And this is why it is now one of the 4 pillars of heart failure management, which includes ACE, ARB, ARNI, and ARNI, which I mean Entresto, is preferred, the addition of beta blocker and MRA, and also now SGLT2 inhibitor has become the 4th pillar to prevent heart failure complications in these patients. Next, please. So when you looked at the pooled analysis, so this is why they're allowed to do this. They have the 4,000 odd patients from DAPA-HF, low ejection fraction, and the 7,000 patients from DELIVER. Putting them all together was a pre-specified analysis approved by the FDA at the time of the study design, right? And they looked at each one of the endpoints. Is it cardiovascular death, heart failure hospitalization, all-cause mortality, CV death, or together. Next, please. When you put them all together, the entire group of patients, regardless of ejection fraction, look at this, whether the ejection fraction was as low as 15 or as high as 75, there was a significant difference compared to placebo. This is what's called a continuous hazard ratio. And there is no effect of ejection fraction, i.e., whether the ejection fraction was low, intermediate, or normal. Addition of the SGLT2 inhibitor dapagliflozin improved the outcome of death due to cardiovascular death or heart failure hospitalization by almost 20%. So you don't really need an echo to prescribe the SGLT2 inhibitor dapagliflozin at all in a patient with clinical heart failure. You just start the therapy and the patient will improve. You can get the echo later on for deciding things like revascularization or ICD or more advanced therapies. But obviously, you cannot avoid using it and wait for the echo. And I think this is what this beautiful analysis shows you. Next, please. So, which of the outcomes is significant? Well, this is the outcome of cardiovascular death. So there's a 14% reduction of cardiovascular death, number needed to treat about 68, 1% absolute. This is very powerful. We're talking about cardiovascular death regardless of ejection fraction. So not using it means that the cardiovascular death rate will increase by 1.5%. You can't afford to do that to the patient. Next, please. When you looked at the cardiovascular death benefit, again, pooling all the patients regardless of ejection fraction from as low as 15 to as high as 75, dapagliflozin was significantly better than placebo, and the difference is something between 15 to 20%. Obviously more in the lower ejection fraction, but still, it doesn't matter what the EF is. You can tell the patient and be guaranteed a reduction of cardiovascular death compared to placebo. Next, please. What does the patient want out of this problem? Well, this patient, as you noticed, has shortness of breath and palpitations. So in the dapagliflozin studies, in the DAPA-HF and DELIVER, there were analyses looking at the patient's KCCQ, which is a standardized, validated quality of life questionnaire over all domains: physical, symptoms, quality of life, and social limitations. These benefits were seen as early as month 4 and continued for up to 8 months in the low ejection fraction patients, and again seen as early as month 1 and sustained at 8 months in the patient with EF over 40%. And it didn't matter if the ejection fraction was even 60 or 70%, symptoms were improved. So does the patient care about symptoms? Absolutely. This is what drives them to come to you, and this is one of the things that is called patient-reported outcomes. If the patient cannot sense the benefit, they may not continue your therapy. So you have to highlight to the patient, you will feel better and you can feel confident in a validated system that you can get this improvement in addition to the cardiovascular death and heart failure benefit. Next, please. So the guidelines have been updated. This is the ESC guideline to give SGLT2 inhibitor, and it doesn't differentiate between DAPA and EMPA, a 1A indication in reduced ejection fraction, a 1A indication in preserved ejection fraction, and a 1A indication in patients with mid-range ejection fraction or mildly reduced ejection fraction or even improved ejection fraction. On top of ACE and ARNI, beta blocker and MRA in reduced ejection fraction, on top of ACE, ARB, ARNI, and MRA will have a 2B indication. So if you look at this graph, again, it tells you it doesn't matter what the ejection fraction is. If the patient has clinical heart failure, elevated NT-proBNP, you start them on the SGLT2 inhibitor. Now, what's also very important for you to realize is this important point here. When you look at this, in patients with preserved ejection fraction, SGLT2 inhibitor is A1, but ACE and ARNI are 2B because of some different interpretations of the paradigm study. So it is essential to use this therapy in all forms of heart failure. And if you see a heart failure patient not getting these SGLT2 inhibitor, you have to ask why and start it on your own. This is a life-saving therapy. Next, please. The American College of Cardiology has also recommended SGLT2 inhibitor as one of the 4 pillars. If you look at the 4 pillars of heart failure therapy, particularly reduced ejection fraction, SGLT2 inhibitor coupled with ARNI. ARNI here is preferred over ACE inhibitors, MRA and beta blockers, then addition of additional therapies such as vericiguat, hydralazine, ivabradine, and loop diuretics. So this is more important by far than loop diuretics. And unfortunately, in the region, a lot of our patients are receiving loop diuretics without the guideline-directed 4 pillars of medical therapy. Next, please. In preserved ejection fraction, you'll notice that the US guidelines are a little bit different than the European guidelines. In the preserved ejection fraction, SGLT2 inhibitor is number 1 to reduce CV death and heart failure hospitalization and clinical status. And then it tells you can add ARNI, or you can add loop diuretic, or you can add ACEs and ARBs and MRA. So now it is the first line agent in preserved ejection fraction, largely because of the data, similar to the European guidelines. But I think visually you can see what is being missed here is that patients are typically given loop diuretics like furosemide, and they're not getting SGLT2 inhibitors. That's not correct and not consistent with the guideline. Number 1 is SGLT2 inhibitor. Next, please. So, as I mentioned to you before, there is critical underutilization of GDMT. 20% of patients with HFrEF are actually getting total GDMT, when 100% in this lethal disease is essential. Optimal guideline medical therapy combination is supposed to reduce mortality by 70% and improves quality of life. So it is really essential to improve GDMT implementation. The 4 pillars have to be given. When we talk about pillars, it means you cannot support the building, i.e. the patient, without the 4 pillars. So this is the key point. And you see now in the across the board of heart failure diagnosis, low ejection fraction, normal or in the middle, SGLT2 inhibitor actually has the first and most important therapeutic role. Next, please. So just to summarize a lot of data, and I hope I haven't overloaded you with this, there's a very strong clinical evidence for treatment of heart failure with both cardiac and renal protection in patients with and without diabetes, with preserved ejection fraction and reduced ejection fraction, reduces the risk of cardiovascular death or heart failure, consistently lowers it regardless of the ejection fraction, i.e. echo is not important to start SGLT2 inhibitor, sustained symptom improvement that can occur early, which is very important for the patient to feel better and continue with the treatment that you're giving them. There are pillars of heart failure treatments, and in core therapy for heart failure, reduced ejection fraction, as well as preserved ejection fraction. And as I mentioned, the benefit occurs within 14 to 28 days. So when you recognize this patient, you must start the treatment as soon as possible, because otherwise the risk of heart failure recurrence and CV death has increased. Thank you very much for this discussion.
Well, we will continue with the Q&A, but first we have to summarize all the great clinical case discussions that we have. And I thank all the audience because all your proactive participation with the clinical case resolving and contributing to discussion. So now I will ask Dr. Jalal Altai, Hani Sabur, and Hamed El-Karai to join us for the last summarize before to enter to the Q&A. Thank you.
Okay, thank you. Thank you, Professor Suarez. Thank you, dear colleague members who presented. In summarization, I take this opportunity to again encourage you to early screen for type 2 diabetes complication, because these start as early as in the pre-diabetes stage. So we have Forxiga as a 10 milligram tablet, so in the actual size right now. It's the starting tablet for CKD, heart failure, and type 2 diabetes. But in cases where there is severe hepatic impairment, like Child-Pugh B, we can start with a 5 milligram dose. It can be safely added for existing heart failure therapy and diuretics, to other common cardiovascular and type 2 medications, and we can prescribe it to eGFR above 25. And with this, I thank you. I leave the floor to Dr. Ahmed.
Thanks, Professor Ganal. And
Thank you.
here, as you can see, the FORSEGA has established CKM, or cardio-kidney metabolic protection, which is the preferred nomenclature right now, even more than the cardiorenal protection. And it prevents, it can use in the prevention and treatment of patients afflicted with this CKM. As you can see, the DECLARE have shown the efficacy in the type 2 diabetes patient. The DAPA-HF shown the efficacy, as you have heard from Professor Sapur, in the HFrEF, and the DELIVER in the HFpEF, and the DAPA-CKD for any patient with a GFR more than 20 milliliter per minute. I can tell you that the Taiwanese study now extended to the low GFR down to 15 milliliter per minute, and any patient with any evidence of proteinuria, and even you should, and we have to stress this, once you started, do not stop it, even if the patient get to the GFR lower than 20 milliliter per minute, till he reaches dialysis or transplantation. And maybe we will hear soon that it's to be used in indicated patient on dialysis, like in heart failure patient on dialysis. And a remarkable number of reports are using in immunosuppressed and transplanted patients, as well, as we will see in the near future. And we can go for Professor Sapur for the summing up of the rest of the talks.
So thank you to both my co-speakers.
Can we move
I
on?
think the important thing is when we are, yes. I was just trying to highlight this point here. If you look at side effects in vulnerable populations, so when you look at heart failure with reduced ejection fraction, again, these are sicker patients, lower blood pressure, lower ejection fraction, a lot of CKD, it's very well tolerated. So the risk of fracture, volume depletion, renal improvement actually protects the kidney. The risk of hypoglycemia is very low, certainly no risk of hyperkalemia, and minimal, not different than placebo in terms of diabetic ketoacidosis. One point comes up very frequently is this false narrative about UTI. These are life and organ-saving drugs. The risk of UTI, if you see here on the lower line, is less than placebo, not statistically significant. And in fact, it is genital mycotic infection that seems to be higher in patients with diabetes that is uncontrolled. So I would never use a UTI as an excuse to stop these medications. You treat the UTI and resume. It is totally different if the patient has serious heart failure and CKD. This is a very important and cause of inertia among both patients and unfortunately physicians. So very well tolerated and very important to continue. Next, if you look at the patients with diabetes in the DAPA-CKD, so these are patients with CKD who had diabetes. Remember, in the DAPA-CKD, half had diabetes and half did not. Again, the difference in the three groups overall, with diabetes, without diabetes, DKA 0, severe hypoglycemia, actually not significant, volume depletion, not statistically significant, amputation and fracture, and certainly no hyperkalemia. And in terms of the renal adverse events, and this is very important, it was less than placebo. This is the proof again that the dapagliflozin molecule protects the kidney in diabetic and non-diabetic patients. It actually makes it less likely to have a renal worsening. And that's why we have to use it for renal protection. Indeed, again, the incidence of serious urinary tract infection in diabetics or non-diabetics is not statistically significant. So you should not withhold these life, kidney, and organ-saving therapies in patients with urinary tract infection.
Thank you very much for this summary. As we have talked about after these 3 clinical cases, we must remember that we are facing a high prevalence disease as type 2D, heart failure, and CKD that is increasing. And the important point is the early diagnosis of all the patients that are without that diagnosis. So all the experts that are connected there, we have to push and to be clear how to diagnose and how that we can prevent and treat heart failure and CKD, and of course the type 2D with the risk. Now we are going to open the Q&A session, and thank you very much. We are receiving a lot of questions about all the cases. Thank you for this contribution. So I will start asking you, Dr. Sabur, about this first question. How soon can we expect renal or CV benefits when initiating Forxiga in high-risk patients?
Excellent question. So in the highest risk group, which of course is the heart failure with reduced ejection fraction, we saw cardiovascular death and heart failure hospitalization benefit within as little as 28 days, less than a month, right? So it becomes imperative from a medical and even an ethical standpoint to start this as soon as possible. So in the hospital, preferably if the patient is being discharged, within 1 week if they come to the clinic, and certainly many people fall off the heart failure pathway. They go to random clinics or they're not properly assigned. So it's the responsibility of any physician who sees a patient who has had a heart failure event to initiate as soon as possible. Secondly, if the patient is diagnosed in the outpatient clinic, which as you see from this particular case, NT-proBNP is a very useful tool that should be used by every physician, primary care, internal medicine, diabetes, cardiology, nephrology. A high NT-proBNP coupled with symptoms of exertional dyspnea, lower limb edema, PND, and orthopnea is not sleep apnea, it's heart failure. And therefore, this patient should start on an SGLT2 inhibitor. We should see a very rapid improvement in symptoms, as we saw from the KCCQ, and cardiovascular benefit, and renal benefit, and heart failure hospitalization. So as soon as possible is when we need to start.
Great, and great for the advice.
Even before arise, diagnosis for ACR, EGFR, for at least symptoms of heart failure, if he doesn't have any previous CKD. So the ideal is people at high risk. I would prefer people with overweight or obesity, those who may present with dyspnea on exertion. All right, before, as Professor Hani Sabur mentioned, it's very useful to use NT-proBNP. I would target people who have, let's say, they want to prevent other future cardiovascular, because we know, and Professor Hani Sabur knows more, that heart failure in the grade 1 stage, it's nearly asymptomatic. That would be the target people. And I, for myself, it's not an indication, even people with EGFR 90 to 60 in the CKD2 stage, I would, especially if they are young, I prefer to target young and early middle age to give them this important medication in order not for the dropping of EGFR decline occurs.
May I also make a comment just to add to what you said, which was really brilliant? Every diabetic patient has to be on this medication.
Yes, you're right.
Right? Because the DECLARE outcome study, the primary prevention arm basically included people with just multiple risk factors. And
Yes.
even from the GFR standpoint, the average GFR was 84. So even the low-risk diabetic patient, this will prevent them from having the complications of diabetes that is most feared. But even if it escapes that initial stage, I think in any stage of CKD and any stage of heart failure. So practically most of the diabetic patients, as you know, in the Middle East are multiple risk factors, right? They have
Risk factors, yes.
diabetes. So I think this is really a very simple calculation for our colleagues. But that's sort of my addition. Thank you.
No, thank you, Professor Hani.
Yes,
And,
completely agree. This is a very important drug, and the SGLT2 is one of the classes that are in all the guidelines to start as early as possible.
Before I close up, Dr. Juarez, there's a question popped up, I think, in the chat for the use in type 1. Let us, in the end, answer it if you permit.
Yes, go
In a
ahead.
middle-aged type 1. No, because it's in a middle-aged type 1. It has never been by the FDA cleared any type of SGLT2 for type 1 diabetes, as in the use of diabetes, for purely diabetes. But the EMA cleared it for overweight, more than 25 years of age, and highly focused people who have their keto sticks ready, because we know the rare but imminent complication of EKA, euglycemic ketoacidosis. That's why if these people wants to get a, let's say, a loophole, okay, for using, I think we are using in elderly people with type 1, those who are developed insulin resistance. We know those who survive long ages of type 1, they eventually get to type 2. They have dual diabetes. They will definitely get CKD earlier and heart failure earlier. I don't think there is a problem in using as an indication for heart failure or CKD in these cases. But I again urge that these people should be, let's say, motivated, and they have a keto sticks monitor, because EKA is a probable and possible complication in those people. Thank you.
Yes, thank you for your answer. And well, we have to remember that the dapagliflozin is not indicated in type 1 diabetes. And of course, well, thank you, Dr. Altai. I have a question for Dr. Hamed. Regarding the CKD without diabetes, which is the best moment to initiate the SGLT2 as dapagliflozin to prevent the CKD progression?
Well, this is a very nice question. And the answer would be, it should be used as early as the moment of diagnosing CKD. Once you stated that the patient is a CKD in a way or another, you have to start immediately SGLT2 inhibitor. Simply, we know that through the timeline of a CKD patient, the earlier you start the SGLT2 inhibitor by the extrapolation of the results of the studies, the major studies, all the kidney studies, Credence and EMPA kidney and DAPA-CKD, all of them have shown consistently that you might save the patient years and years of hemodialysis or kidney transplantation of 70 milliliter per minute or even more, 80 milliliter per minute with albuminuria, the more you preserve the patient up to 28 years of hemodialysis. So this is very important. The sooner, the better. As early as you diagnose the patient as CKD by the heat map, whether he in the albuminuria pathway or in the CKD grading pathway, please, regardless of the C, which is the cause, because we now say it's a CGA, C for the cause, G for the grade, and A for the albuminuria. So regardless of the C, whether it is a diabetes or a non-diabetes, please start whatever patient you diagnose as CKD with SGLT2 inhibitor, dapagliflozin, immediately, please. There was a question that I would like to answer about the use of SGLT2 inhibitor in lupus patient or other immunosuppressed patient.
Yes, it was my next question. Thank you to take it.
Okay, this is a very nice question, actually. We already had a paper that had been published 3 or 4 years back in the European Journal of Clinical Pharmacology about a patient with GN, glomerulonephritis, that we have started all of them on Forxiga while having different type of immunosuppression, CNI and steroids. And we had only one clinical attack of UTI in all the patients. There were 17 patients at that time, at the very early start. And this attack was treated successfully, and the patient was reinstituted on the SGLT2. And we had, when we compare these to the regular patient, we had significant delay in the GFR reduction and definitely in the proteinuria. So we know by now from the multitude of trials that are using SGLT2 inhibitor in kidney transplantation as well, that it can be used. The earliest notion for not to use in immunosuppressed patient was probably a company-driven point to avoid the higher risk of UTI in those immunosuppressed patients. But definitely you can go on and you can use them. And this is off record. This is not a guideline. This is not a company recommendation, but it's clinical practice that we all know. It's across the globe. We as nephrologists are using it.
Completely agree with you, Dr. Hamad. Yes, it's not an indication for the Farxiga, but of course the clinical experience go beyond the indication. So this is really good to know and to know your experience in the clinical phase. Now, I have another questions for you too. Is safe to start dapagliflozin in patients without in patient diabetic with GFR less than 30 or not?
Yes, it's in the label.
Well,
Yes,
yes,
you
it's
can
in the
use it
label.
when
Yes,
you have
thanks, Dr.
less than
Hani.
30.
Yes, definitely. Yes, you can use it. As we know, down to 25 milliliter and please, yes, 15, yes. Please notice the difference between starting and continuing. This is a very important point. Yes, you might not start when the GR is below 2 milliliter per minute if you want to stick to the guidelines till now. But if you have started at a GFR of 22 milliliter per minute, and after starting, the GFR dropped within a year, within months, even 5 years to 18 and 17 and 15 milliliter per minute. Please, the guideline states continue on till you reach hemodialysis or you go for kidney transplantation. I mean renal replacement therapy. So do not stop if it fell down below 20 milliliter per minute. And I would take a privilege of being a panelist or a speaker and would go directly for Dr. Hani and asking him about when a patient is already reached dialysis and he is a heart failure patient, whether HFrEF or HFpEF, what's your own clinical practice? Do you stop the SGLT2 inhibitor or do you continue?
Excellent question. So the heart failure benefit continues even when the GFR drops. And we saw this in the DAPA-CKD at the extremes of low GFR. And we can, we have many case series and published case reports of patients' ejection fraction continuing to improve with the use of the SGLT2 inhibitor. So as you pointed out, the point about SGLT2 inhibitor in general is that it does not have a risk or safety problem when the GFR drops, Even in diabetes, it just loses its glycemic efficacy, but it continues to have a remarkable protection on the myocardium, the myocardial epigenetics, the myocardial substrate, fibrosis, and many other things, including interstitial edema in the myocardium and reducing fibrosis and myocardial stress. In fact, we see this with SGLT2 inhibitor when you do serial echoes. So I never stop the SGLT2 inhibitor. In fact, in discussions with my nephrology colleagues, if the patient's continuing on dialysis and they have been on it stable for a long period of time and it's for the cardiovascular benefit, we keep it, right? So I think this is the key point. But as Professor Galal mentioned, in these patients, you have to think of euglycemic ketoacidosis. So you have to monitor them if they end up in these situations in the hospital where they're dehydrated, where they're having surgery, So these are the clinical scenarios, but the overwhelming benefit is to keep on this remarkable therapy in order to preserve the heart. If they've lost a kidney, their likelihood of dying of a cardiovascular event is much higher. Their likelihood of heart failure or sudden death is much higher. So adding the cardiovascular protective therapies is absolutely on par. Now, remember, this has not been tackled in the clinical studies. Very few patients dropped to the range of end-stage kidney disease during the DAPA-CKD study, but I think we know where the clinical evidence is here. The clinical work tells you to maintain. One point that you mentioned, very important, people get scared when the GFR drops, right? This is true. This is called the GFR dip, yeah? But
Normal.
if you look at the studies themselves, you see that the reduction of the worsening of GFR is attenuated by the SGLT2 inhibitor. So over time, it's much more protective than leaving them without this treatment.
Can I
Well-
comment also, Dr. Sonia?
Yes,
Thank you
please.
for.
We had a problem. We used Forxiga because it was an anti-diabetic drug back 7 years ago. 7 years ago, nearly, when it was in the market. We had the first problem, as Professor Hani Sabur mentioned, the dip. I would like to target the audience. Every medication affecting the afferent arteriole will have 6 to 8 weeks increase in serum creatinine, therefore reduction in eGFR. That was the same problem when we were using the RAS inhibitors.
Exactly.
That's why I prefer to address the audience not to do an eGFR at least 2 months when you start using the Forxiga or other SGLT2 inhibitors.
Yeah, thank you for the comments. Yes, I completely agree. And I have another question for Dr. Hani. Today I have a lot of questions for heart failure. Well, this question is more about acute coronary syndrome. What is the role of use Forxiga after an acute coronary syndrome event if in the absence of type 2D or heart failure?
Okay, so there are small studies that look at this particular phenotype. However, the current label and guidelines do not mention this specifically. I would say that if you have an ACS patient, right, that is not diabetic, look for additional subtle features. For example, do they have albuminuria? So if you have microalbuminuria, they become a DAPA-CKD patient, right? If they also have a elevated NT-proBNP, they may have diastolic dysfunction, which is not overt heart failure. So this is sort of a partially off-label indication. But remember, why are we looking to try to put every patient on this therapy? And I mean this not in a trivial manner, because it has a remarkable organ effect that saves the heart and kidneys. Now remember, Professor Eugene Braunwald in 2022 said that SGLT2 inhibitors are the most powerful therapies. They are the statins of the 21st century because they do much more than statins, right? They protect the heart, the kidney, the metabolism, all of the vital organs. They add life and years to the patient. So when I'm seeing a patient, I'm looking at them from a CKM standpoint. If they have atrial fibrillation and an elevated NT-proBNP and a mild diastolic dysfunction, excellent. That's a patient with very early stage heart failure in the transition from A to B. And here, only SGLT2 inhibitor is indicated, right? If I have a post-ACS patient who has a normal ejection fraction, but grade 2 diastolic dysfunction, slightly elevated NT-proBNP, remember the cutoff point in the outpatient clinic is 125. Okay, in the inpatient, it's a little bit different, right? Or if I check their GFR, it's normal, but their urine album creatinine ratio is 90. So it's above 30, right? These are all good indications that are evidence-based, but not specifically mentioned. But in answer to your question, just ACS, there's not a very clear indication.
Well, we are arriving to the end of our meeting, so I will ask this last question. I know that we have receiving a lot of questions, and thank you for the engagement. And well, these questions I open to all of you. How does CKD affect troponin level?
Well, it's a very nice question, but yeah, go ahead, Dr. Hani. We have to differentiate troponin I from troponin T in a cardiac patient. Go ahead, Dr. Hani, please continue on.
No, I was going to come back to this point. So the cutoff points for hypersensitive troponin, fifth generation high sensitive troponin I or troponin T, are modified by kidney disease. patients with more advanced kidney disease are likely to have what's called troponinitis. So, when they use the cutoff point of 14, many of these patients have elevation of the troponin. This is not an indication of acute coronary syndrome, but it is an indication of increased cardiovascular risk, and it is an indication of progression of heart failure and cardiovascular strain. So I use that to reclassify the patient from a cardiokidney metabolic state that they need more intensity statin, that they need more RAS blockade, and more prevention in general. I mean, I think the key point is, and you've pointed this out multiple times, is that when the patient has kidney disease, they're 2 to 3 times more likely to die of a cardiovascular event or heart failure.
This is very good.
There's a question that
yes,
there's
just go
a
ahead,
very
Dr.
burning
Khan.
question that I'd like to answer because it's very, very unfortunately mistakenly in the practice. The question is: patient with non-symptomatic pyuria refractory to antibiotics, can we safely prescribe Forxiga? I would like to rephrase the question. Patient with non-symptomatic bacteriuria, even not only pyuria, should not receive antibiotics except in a very, very subtle clinical situation. That's to say, in a pregnant female, in immunosuppressed patient only. And even in immunosuppressed, the indication is being withdrawn in some of these patients, even in transplanted patients. So if the patient have asymptomatic pyuria or asymptomatic even bacteriuria, that's to say culture positive, with no symptoms, with no lower GI tract symptom, no LUTs, and no systemic manifestation, no pyelonephritis, this patient should not be treated by antibiotics, number one, and should not be, withdrawn or abandoned from having the SGLT2 inhibitor. They should have it, and there is no problem. And please do not test for pyuria or for urine analysis for the sake of pyuria or bacteriuria in asymptomatic patient, because you should not treat. And go back to the updated guidelines of the UTI that have been just released from the ADSA, or the American Society ASDA of infectious diseases, and you can find that you should not treat asymptomatic bacteria and pyuria in all these patients. And please, yes, give the Forxiga in those patients. There is no problem with that.
Thank you, Dr. Hamid. I would like to thank all of our panelists and the great discussions that we have this evening. Dr. Jalal, Dr. Hani, Dr. Hamid, thank you very much for these discussions, for the great clinical cases that we went through. And of course, we are going now to summarize and to end the meeting. So for summary, it's important that we already have Forxiga included in the treatment guidelines for type 2D, for CKD, and for heart failure. For CKD and heart failure, we know that is a third pillar of treatment, for 4 in the heart failure and for 3 in the CKD. So we have to remember that we have very good trials that has been discussed by our panelists already about the benefits of using Forxiga in heart failure with DAPA heart failure, and on CKD with DAPA CKD, and all the pivotal trials that we got in type 2D that help us to completely realize that we can stop the decline and the progressive CKD if we use it early. And we have the decrease of renal or CVD death and albuminuria when we use it versus placebo. Regarding the heart failure part, we have with using Forxiga, we have the risk of CVD death worsening in the risk of CVD death and worsening heart failure, as we have already discussed, and improve the symptoms for patients that are already living with heart failure. We know now that we have 3 important points to remember. We need to focus on early diagnosis, and our doctors mentioned the early use of Forxiga to avoid these complications and to improve the benefits of life and quality of life in this kind of patients. And the third one is that we need to push our efforts together, cardiologists, endocrinologists, nephrologists, to see these patients together and remember that we have this kind of drug with great benefits that are only for the ESGLT2 as Forxiga. Thank you very much for your attention all these 2 hours, for this evening with us, and have a nice weekend to all. Thank you.
Thank you.
Muy honorado.
Thank you. Thank you.
Thank you
Thank
so
you.
much
See you
for
all
your
soon.
joining.
Thank you all.
Thank you.
Bye.
Thank you for joining.
Assalamu alaikum.
Salam.